cardiologists we ever known to speak about the management of perioperative anticoagulation. So please, sir.
شكرا جزيلا chairperson. شكرا for organizing committee to invite me. أنا سعيد جدا أبقى معاكم وأشارككم. إن شاء الله تكون مشاركة كويسة. هم أصحاب القلب هم متعبين شوية في محاضراتهم لكن نتحملهم شوية. So the topic it will be about the management of preoperative anticoagulants, which is a dilemma of cardiologists, medical doctors, and who is going to operate in such patients. At the beginning, I have nothing to disclose. It's a matter just to share you, to meet you in such nice meeting. Usually when miss or find a case that's going to surgery, is under anticoagulants, is liable to get thrombosis, many things is coming to the mind. And even that who is going to operate, who is going to take care of such patients, so just keep in his mind these type of questions. Yes, no, maybe, what I'm going to do, a lot of things there. So the agenda of this talk will be talking about the risk of bleeding during surgery, the risk of thromboembolic phenomena, how to classify the anticoagulants, when to give it and when to interrupt, and when to do bridging between different anticoagulants. And then if you are going to go for urgent surgery, how to manage, and then what is the final result, I'm going to give it to you. So if we think about such things, you know, it's not moving simply. So keeping in mind these questions, the beginning of such cases, the first question was the preoperative bleeding risk of such patients. The second question, what's the preoperative thromboembolic risk of such patients? And the other questions is the patients with anticoagulations. Can the anticoagulations continue or could we stop these anticoagulations? The others, does these patients need bridging or he doesn't need bridging of such patients? There is a general approach, it's the concept in mind that if I'm going to continue anticoagulants, so the patients may bleed. If I'm stop anticoagulants, that the patients may get thromboembolic effect. So both of them, they affect morbidity and mortality of the patients. And just to do adjustment between all of these medications, so this is the message of the problem solving for such patients. So to keep it, how is the idea? You make it balance between thromboembolic phenomena and between hemorrhage during surgery. What's the end result? It is patients versus procedures. So you will keep the patient safe, or the procedure is better for him to do it or not to do it. So the other things, the risk of bleeding, we have many patients that are liable to bleed. So they classify the surgery to these three categories. The first category, these patients, they have risk of bleeding is higher, so more than 2%. So this is the major surgery, extensive tissue injury, cancer surgery, reconstructive surgery, clinic surgery, ERCP, any major surgery take more than 45 minutes. These are the liable to bleed. The risk factors of bleeding is less in such type of surgery, continuous lymph node biopsy, GI endoscopies, laparoscopies, cystectomy, abdominal hernias, or hemorrhagic surgery. This patient who is not liable to bleed, like catheter surgery, or dental, or minor dermatological procedure or surgery. So if we see the risk of bleeding, who's the patient is going to bleed, so this is recent active bleeding, has an instance or gas GIT bleeding, trauma, and so on. So the chronic liver disease patients, they are liable to bleed. So we keep mind in these patients. Patients and the underlying bleeding disorders, and the patient they have thrombocytopenias, also they have a risk to bleed. What's the risk of thrombosis? So we make it either it is patient risk or surgical risk. The patient risk, those patients, they are liable to get thrombosis during surgery. So major medical illnesses, obesity, previous thromboembolic events, cancers, overage, prolonged embolizations, lower limb surgery or paralysis, hormonal therapy, he was on hormonal therapy, and had comorbid conditions like congestive heart failure or myocardial infarctions. The type of surgery also play a role. This type of surgery, they are liable to get thromboembolic phenomena. The hip or lower limb surgery, surgery of cancers, neurosurgery, spinal surgery, or multiple trauma surgery. and even associated because of prolonged surgery, whatever it will be, they are liable to get thromboembolic phenomena. Sometimes type of anesthesia or the post-operative mobility, they are liable to get surgery. How to manage or how to adjust these patients? They will do what we call modified Cabernet risk score. So they just classify the people in these categories. This patient, they have just low risk, the risk is 1 point. These patients have the risk of 2 points. These patients risk of 5 points. And then they meet just classification of these patients who is going to get thromboembolic phenomena or not. And how to behave. If these patients have high risk of thromboembolic phenomena, that means just simply, if you have high risk, that means Cabernet score is 5 and more, and this is liable to get thromboembolic phenomena. So what you will do, just give him prophylaxis, low molecular weight heparin, start to mobilize the patients, or you may do just combinations of such patients. Who is the patient have higher risk of thromboembolic phenomena? Just we consider these patients with atrial fibrillations, prosthetic valves, or recent thromboembolic phenomena, thromboembolic embolism. These patients, this type of categories, they should take care of them, that they are liable to get thrombosis. We should just manage them aggressively. And such patients, they should consider referral of cardiologists or hematologists to manage them. What's the classification of anticoagulants? The era of anticoagulants started in 1930s, and it is going on like that. And even nowadays, we are going to use the new types of oral anticoagulants like the dabigatran, rivaroxaban, or apixaban. And then it is taking the upper hand of management of thromboembolic phenomena. Before just we see this is the warfarin, the new oral anticoagulants, and then other antiplatelets and the thromboembolic phenomena. What we are afraid really we may success in doing the surgery, we may success and help the patients to just reconstruct what the problem, but we may just end in bad sequelae to the patients and because of bleeding or thrombosis. So just this other classification of anticoagulants, either to prevent thrombosis like anticoagulants or antiplatelets, or just to do vasodilatations for the blood vessels, just to move the blood. And the other type of anticoagulants is removing of occlusions like thrombolysis or angioplasties. Whatever use the types, just make it in considerations during surgery. So how we can do for such patients in a surgery, how to do for different type of anticoagulants during surgery. So we'll take one by one of them. So the one which is the famous one is warfarin. So what we are going to do, if we are going to do the surgery and you schedule the surgery 5 days, so we have to stop warfarin 5 days prior to surgery. And if we need to restart it again, so you'll start it immediately post-surgery, or you consume it immediately after surgery if the surgical procedures is completely without any bleeding tendency. As we need to do at the bridging, we don't need to use the bridging. We need to adjust that the INR of patient is becoming less than 1.5, then you can go to do the surgery like that. If the patient will be bedridden for a long time, that's you can do bridging. You give the patients just like low molecular weight heparin. This is the idea. If we are afraid from bleeding of warfarin, so if we are afraid this patient is liable to get a bleeding or thromboembolic phenomena, whether he may bleed or he may get thrombosis. So what we are going to do? So we have to stop warfarin 5 days before surgery, and when to continue it back again after surgery when you are secure all the things. So this patient who is liable to get thromboembolic phenomena, that you are going to do what we call is bridging. So that's when you stop warfarin and then you give the patients low molecular weight heparin or heparin just till you start the surgery, the day of surgery. So the night of day's surgery, you stop morning dose of low molecular weight heparin, check the ANR of patients, and then go for surgery. Immediately, if you secure the surgery, no more bleeding and stable the patients, so do what we call again bridging for such patients because they are liable for thrombosis. Again, enter the heparin for a period of 2 or 3 days till the ANR becoming more than 1.8, and then you can continue warfarin, and then you stop the heparin. If the patient is under antiplatelets management, like aspirin or clopidogrel, such anticoagulants nowadays, yes, they can continue surgery unless it is major surgery with aspirin, and no problem it will happen to the patients. So if you think this patient is liable to get risk of bleeding, you stop such type of anticoagulants 7 to 10 days prior to surgery, and then you can resume them immediately after surgery. If you need to do bridging, if you are afraid this patient is liable to get thrombosis, you can just give such patients low molecular weight heparin in a prophylaxis doses. So you may consider it. If the patient is under the new oral anticoagulants, so these types of anticoagulants, you can stop them 1 to 2 days prior to surgery, and you can resume them immediately after surgery. If you guess this patient is liable to get thrombosis or other things, so you may do bridging. But such patients who is under this type of anticoagulants is not liable to get more thrombosis, so no bridging could be done prior to surgery, because you stop them 1 or 2 days immediately. So that if he's just to be prolonged after surgery, so you may do bridging for such patients for 1 or 2 days. And then they depend how they act, these anticoagulants, and what they are the creatinine clearance for adjustment of such doses. This is a different type which is used nowadays in new oral anticoagulants, dabigatran, rivaroxaban, apixaban, and edoxaban. يمكن اللي موجودين في اليمن these 3 types of anticoagulants, they are taking the upper hands of management of coagulations, of thrombosis management. So if you are going to do a switch between the different types of anticoagulants, how you are going to do, simply this is the job of cardiologists. So just, if the patient, simply I'll give you an example. If the patient is under new oral anticoagulants, immediately you can stop them, and then you just give warfarin, and then just adjust the ANR for the patients, and then replace the warfarin instead of new oral anticoagulant. This is the different ways how to adjust or how to switch different type of anticoagulants from one to the others. And this is, I think, the job of cardiologists. So when you are going to do bridging of anticoagulants, so when you are going to replace the warfarin by another anticoagulant, so this is just the warfarin. The ideas for bridging is mean that you are going to adjust and to replace warfarin to replace warfarin by heparin. Warfarin, by the way, who are somewhat tiramus. This is the idea. Just I keep it like that. So the idea just to replace warfarin by other anticoagulants like heparin. How you will do and when you are going to do it, if this it is strongly recommended in such patients just to do replacement. This patient he had deep venous thrombosis or pulmonary embolism with the last 3 months, or severe thrombophilia, mechanical valves. You should just do bridging for such patients, or any mechanical valve with the history of a stroke or transient ischemic attack. This patient, you should just do bridging. Bridging, the idea here, you should not keep patients far away from anticoagulants. So that means patients is under anticoagulants by any means during surgery. So if the patient has non-valvular atrial fibrillation and his CHA2DS2-VASc score is high, so that means he's liable to get a stroke or TIA or had thrombosis. So you should do bridging for such patient. It's not recommended to do it in any patient who is not liable to get thrombosis. The idea or the risk of thrombosis is low, but it's not an idea to do a thrombosis. Even if you are going to use it in atrial fibrillations as a prophylaxis, this is not the idea to do it. So it's better to do it in patients he had high risk of thromboembolic phenomenon. This is the idea of bridging. That means you just made a cross during surgery for such patients to replace them from long-acting anticoagulant by simple short-acting anticoagulants, and then you can just replace it very simply. So these are the therapeutic uses of bridging type. Either to use Kilexan, the simple one. If it's just you use it in therapeutic dose, it will be 1 milligram per kg subcutaneous BD. As intermediate, that means the patient is not liable to get a high risk of thrombosis. You just give it 40 milligrams subcutaneous BD. It's just you give it of prophylaxis obese patients, or the patient is bedridden. This is a simple dose. It's just use it is 20 to 40 milligram once. So the bridging it used in patient, he is liable to do thrombosis in high doses, therapeutic doses for this patient liable to this thrombosis, a low doses gas prophylaxis regimen, intermediate doses, you may use it sometimes. If this patient has high risk of thromboembolic phenomena, especially from the lower extremities, such patients, they may use during surgery as inferior vena cava filter, which is rare to be used unless you need it in patients with high indications. If you are going to do different type of surgery, if the surgery is urgent or not urgent, the situation here is different. So for urgent surgery, no way to think. So the most important things in the management of such patient to save his life. So that means immediately you reverse anticoagulants, do the surgery. So reverses by different type of reversal. The most common reversal of anticoagulants, prothrombin complex concentrations, which is not available in Yemen. So why it is important? Because it is very simple things. You will do it to the patients, immediately the bleeding tendency, it will be decreased. But this is not available in Yemen. What is available in Yemen is plasma concentrations or gas fresh frozen plasma. So if the patient is gas under warfarin, immediately you are going to reverse for urgent surgery. If it's gas the ANR below than 3, then immediately you just give vitamin K anticoagulants or just to reverse warfarin and oral dose. Keep in your mind, if the patient is under valve replacement, it could be a serious thing to give high doses of anticoagulants immediately because the valve is liable to get stuck and to be closed. If the ANR of more than 3 and less than 5, so this means you are going to give vitamin K in oral dose, or you just give fresh frozen plasma if the ANR exceeds than 5. So it gives vitamin K orally, fresh frozen plasma if the surgery is urgent. So you replace it immediately by the rapid reversal by fresh frozen plasma, vitamin K, or slow intravenous. If it's gas, you dilate for 24 to 48 hours. That's mean you just reduce it slowly, not urgently. This is the warfarin, how to reduce it, either by vitamin K or fresh frozen plasma. Dibigatran, you just do reverse it by edorizumab, or if the patient under ibixabam or rifaroxabam, indoxinate, it used as a reversal. The low molecular weight by fresh frozen plasma or protamine, antiplatelets, so you give antiplatelets or just blood transfusions to give it for these patients. Keep in your mind, if the surgery is urgent, the most important idea for surgery. So if the surgery is not urgent, so it's easy to just reduce the doses gradually. So keep in all of these situations, the patient should be informed of all in steps that you are going to do. Either you do just inform the patient in basic things and not in a complicated things. If he is complicated things, the patient will enter in dilemma, try to make it in a simple way. So the final message of my talk, again, to keep this patient is liable to bleed or not to bleed during or before surgery, or he had thrombosis or not thrombosis, and the other points, this patient, you should continue or you stop anticoagulant, you should do bridging or not to do bridging for the patients. So my final message or taking home message, anticoagulants is the serious drugs, but they are essential in a medical life. To avoid complication pre-surgery, it is the myth, and you have to solve it with the cardiologist or doctor in charge. Different type of anticoagulants need different type of actions. Not all anticoagulants to be managed the same. And the other final message is discussions and consultations is mandatory between the surgeons and the cardiologists on a charge. Thank you.
when we have bleedings in after any surgery, we said, oh, that patient, we found that he was under aspirin and the problem, and we had bleeding. Or he just stopped aspirin 2 days before the surgery, so we faced a difficult surgery and we had bleeding. Now, how can we explain? This is the first point. Now we can proceed with the surgery without stop of aspirin. The second question, just about the prophylactic dose of enoxaparin or Clexane. I don't know what is the practice of my colleagues, but we used, I personally used to give the low dose or 40 milligram for thin or low weight people, and 60 and 80 milligram OD subcutaneously for more large or high weights. But here I saw the prophylactic dose only 20 to 40 milligram. So we have to adjust our dose to go just for not exceed 40 milligram. Thank you.
شكرا دكتور خالد. هو الايديا اوف اسبرين، بس انا كنت اسال واحد طبيب جراحه مسالك، انت بتجيب لي الحالات المكلكعه هذه ليش؟ ليش والبقيه المرضى فينهم؟ قلت انا بتعامل معهم من نفسي. هي المشكله في هذا complicated patient. Simple patients كمان كانت من اول مشكله انه الاسبرين just you stop it and then you get bleeding like that. ما ادري هل هي شماعه احنا بنتعلق فيها ولا. الان the new guidelines you should not stop aspirin, you can continue on aspirin. لكن in our situations ووجود المجلس الطبي ما يدور اي حاجه بيتعذر فيها على الاطباء، ولو في حد واحد منهم يسمعنا لو هذا حيقول لك ليش ما وقفت الاسبرين وكان في مشكله وان الاسبرين يسبب النزيف. No, the new guidelines should not just stop aspirin, especially in the surgery, it is simple surgery, plain surgery, you can adjust to the management of bleeding tendency. If you are afraid of bleeding and afraid of such places, so it's better just to keep yourself first and safe. The other points of anticoagulants depends well what's the patient's in front, prophylaxis, what the patient's in front of you. If he is immediately mobile after surgery, so it doesn't need to give anticoagulant, prophylaxis. If he gets obese, bedridden, with comorbid conditions like diabetes, obesity, hypertensive, heart failure patients, it's better to give as a prophylaxis low molecular weight heparin. Low doses for the patients with low risk, high doses for the patients of high risk. Low doses 20 40 once a day. The patients عندهم comorbidity, it will be 40 BD. As severe, so it will be 60 BD. Immediately if you secure your bleeding tendency.
Excuse me, Doctor. I am Dr. عائشة علي. I'm a gynecologist. شرف كبير لنا نحن نتواجد في مؤتمر ومع البروف يعني مع البروفيسور نور الدين ومع كل الأساتذة الكبار. My question, I have a portal vein thrombosis. It happened before 1 year. No, I have portal vein thrombosis. Yes, I have it before 1 year. Now I am on warfarin 5 milligrams daily. But my question is, do you advise me to continue with this drug all my life? I feel depressed from this actually.
I advise you to revise your doctor in charge.